Hello, dears, and welcome to Al-Hussaini Virtual Lab, Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of choroid plexus papilloma in the fourth ventricle of an adult patient, and this is the trick. So this is a 42-year-old female patient who presented with headache and was found on investigations to have fourth ventricular lesion that, as you can see on low power magnification, shows this beautiful papillary, very clear papillary architecture with some calcification. So zooming in on high power, you can see the papillae, very well formed fibrovascular pores lined by a single layer of bland looking epithelium. Here is as well, and the pores sometimes typically in choroid plexus papillomas can show aggregation of foamy macrophages in addition to some samoma calcification. And again here, the pores of the fibrovascular pores of the choroid plexus papilloma and the bland-looking epithelium, sometimes forming some solid sheets, but in general, there is no evidence of atypia, no mitosis, and this is extremely important to rule out the diagnosis, for example, of atypical choroid plexus papilloma, or the most important differential diagnosis in this setting, in this age, is metastatic carcinoma. And another area with fibrovascular pores lined by a single layer of bland-looking epithelium, or here the same fibrovascular pore and a single layer of bland-looking epithelium, again repetitive here, fibrovascular pore and a single layer of bland-looking epithelium with some clearing of the cytoplasm and then some samoma formation. And again, there is no evidence of mitosis. One peculiar area in this focus in particular showed what looked like invasion into the brain parenchyma. And actually, this was confirmed with GFAP positivity. This is the same focus with some positivity at the edges here. I'm going to zoom in here, but also some positivity of the tumor cells themselves with GFAP. Remember that choroid plexus tumors in general can show some positivity with GFAP. The main differential diagnosis with the papillary architecture would be ependymoma. However, what I would like here to highlight and show you is the focal infiltration of the choroid plexus tumor into papilloma, into the brain parenchyma here and here. And this is very important. Pitfall invasion into the brain, unlike meningiomas, for example, does not change the grade of the tumor. So it's a feature that we can see in choroid plexus papillomas, in atypical choroid plexus papillomas, or even in carcinomas. Per se, invasion into the brain does not alter the grade of the tumor. This is extremely important to know. Now, EMA is completely negative, thus ruling out the important differential diagnosis of ependymoma, as well as remember that it's very important in adult patients to rule out carcinomas. And it's quite unusual for any carcinoma to be an EMA negative. So this is also helpful to rule out indirectly other potential of metastatic tumors, such as, for example, thyroid papillary thyroid carcinomas or other forms of papillary tumors metastasizing to the brain. Pancytokeratin is typically positive in choroid plexus tumors in the absence of EMA positivity. So typical choroid plexus tumors would show pancytokeratin positivity, EMA negativity. This is the typical pattern. But remember, the most important confirmatory immunohistochemistry is a transthyretin, which usually shows this a granular cytoplasmic positivity here and here, thus supporting the diagnosis of choroid plexus origin of the tumor. P53 showed this mosaic pattern of staining, so this is not the mutant pattern or the abnormal expression pattern, and the Chi67 was low in this instance, supporting that this is choroid plexus papilloma. I did also PAX8 immunohistochemistry as well as as TTF1 immunostains, and both were negative, to rule out the possibility of metastatic carcinoma. So the final diagnosis in this case was choroid plexus papilloma, CNS WHO grade 1. Remember that in adult patients, choroid plexus papilloma can occur in particular in the fourth ventricle, as is our case. Remember that sometimes we can encounter some macrophages in the papillary pores, and this is commonly described, as well as the calcifications also commonly described. The samoma bodies commonly described in choroid plexus tumors, including the papilloma. Remember that brain invasion does not change the grade of choroid plexus tumors, so the papilloma stays papilloma, the atypical stays atypical as per the criteria. Unlike the meningioma, brain invasion does not alter the grade of the tumor. And remember that GFAP staining can be positive, but it's important that the combination of EMA negativity, cytokeratin positivity would really, in the right context and in the right morphology, support the diagnosis of choroid plexus papilloma. In an adult patient, you have always to rule out malignant metastatic tumors, in particular from the thyroid and from the lung. I hope you find this tip useful in your daily practice. Thank you.